Welcome, everyone. It's my pleasure this morning to introduce our speaker for today, Eileen Doherty, who's here with us. She is the Executive Director of the Colorado Gerontological Society and has held that position since 1982. She also currently teaches at the Fort Hays State College in Hays, Kansas, on managing nonprofits. Eileen started her career in this field in her early 20s when she had obtained a grant to research using nurses' aides in the care of the elderly. That just started a 38-year distinguished career in this area. She has done clinical practice research, teaching, training, and been actively engaged in public policy creation and bringing to fruition. For example, Eileen was involved with the people who first proposed living wills in Colorado, that legislation. Given her career, Eileen has earned well-deserved recognition, and just two of the awards were on this card, but they deserve mentioning. The Regional Director's Citation for Medicare and Medicaid Beneficiaries, that was awarded by the U.S. Department of Health and Human Services, Region 8, and the Frank Ishida Award from the Centers for Medicare and Medicaid Services. So, as you can just hear from those awards, Eileen is the perfect person to bring here today to talk to you about Medicare reimbursement and end-of-life decisions. Please help me in welcoming Eileen.
Thank you for that very kind introduction. It always sounds really impressive, but I'm still the little farm girl from western Kansas, you know, who went to the 5-room schoolhouse, or the 57-person schoolhouse with 4 classrooms and 5 people in my 8th grade graduating class. So, be that all as it may. What I'm tasked with this morning is to talk to you a little bit about Medicare. There we go. Medicare reimbursement. And so what I thought we might do for a couple of minutes is to talk a little bit about the health insurance trust fund itself, and just to make sure that everybody kind of knows what comes out of Medicare. So the first thing is that we have Medicare Part A, which basically covers 4 things, okay? It covers hospital costs, all but basically the initial deductible, which this year is around $1,182, and you have to pay that every 60 days if you go to the hospital. It pays for some skilled nursing or rehab up to 100 days. There is a copay after day 21. It pays for limited home health, about 100 visits, and it pays for hospice care. So it's important to kind of know where you sit. And the Medicare Part A, actually that's wrong, that was supposed to go to Part B. Part A is financed basically out of the general fund, okay? So when I pay income taxes, then I basically pay for Medicare. And if you pay other kinds of taxes to the federal government, whoops. Now the solvency of the Medicare Health Insurance Trust Fund basically is paid for out of payroll taxes. And what you need to understand is that in 2011, the payroll taxes basically covered 0.9% of the cost for Medicare. That is going up, or went up in 2012 to 1.35%. So what we basically have created in this country is a situation where the assets or the amount of money in the Medicare trust fund is less than the amount of money that is needed on an annual basis to pay the claims that are presented. So even with the amount of money that we have designated for that, we have fewer dollars in that trust fund to actually pay for that. The projections are that we will run out of dollars in 2024. That is the same number in 2012 that it was in 2011. So there were some savings that were realized from 2011 to 2012. By 2024, we'll be able to pay 87% of the cost for the Medicare reimbursement. And it's projected to decline to 67% by 2045. And then once those of us who are in the baby boom generation, of which I am in the middle of, sort of die, they presume that probably by 2045 I will not be around. And that's probably pretty close, because by then I would be 53, so I would be about 97 years old. So I probably won't live that long. And I'm right in the middle of the baby boomers, because the baby boomers from about 1946 to about 1957. So as the baby boomers die off, we will basically have less demand on the Medicare trust fund. So again, it can start building up. The question really becomes what's going to happen as we put more demand on that trust fund. Medicare Part B then is what's called the Medicare Supplementary Medical Insurance Fund. And Part B pays for such things as doctor's visits, labs, x-rays, outpatient services, ambulances, emergency rooms, chiropractor, all of those kinds of things. The supplementary insurance also includes Medicare Part D, or the prescription drug benefit. And as some of you may know, that was one of the big contentions during the passage of the Medicare Part D law under President Bush, was the fact that we did not have any money designated from any funding source other than the general fund to be able to pay for Medicare Part D. Now, there's a lot of discussion out there about how seniors are very happy with Medicare Part D, and I think the latest statistic that I saw shows that about 87% of seniors are happy with the Medicare Part D benefit. So it's very popular, people like it, but at this point in time, there's no dedicated funding source. So that has to come out of the general fund as well. The way that Medicare Part B is funded is basically under the premiums. So at this point in time, the Medicare Part B premium is $104.90 per month. And probably for most of you, that comes out of your Social Security check. For those of you who may be government employees, you may not be under the Medicare benefit, and you may need to pay that Medicare Part B premium on a monthly basis or a quarterly basis, depending on what kind of an arrangement you have with Medicare. The Medicare Part D premiums basically vary by plan. They can range as low as $18 this year per month, and they can go as high as, I think the highest one was $204 or something like that. So there's a very, very wide range in terms of what the Part D premiums are. Now, the part of the Medicare Supplementary Medical Insurance Fund is also projected to grow very rapidly, and in 2011, it represented 2% of the gross national product, and by 2034, it's expected to go up to 3.4%, and then go a little bit more slowly by 4%. Now, some of my friends who are better at this health policy stuff basically tell me that this is a bunch of gibberish, because who could predict 75 years out what this kind of growth is going to be? And if we look back in the very recent past, who saw the 2008 basically recession come. So these kinds of projections are always very nice, and they sound good and they sound interesting, but sometimes they don't really have a lot of validity. So the solvency of the Medicare the Supplementary Medical Insurance Plan, basically the Affordable Care Act tried to make some attempts at how are we going to make Medicare solvent, if you will. And the biggest thing that the Medicare, or that the Healthcare Reform Act did, or the Affordable Care Act did, is it basically said that it was going to take $807 billion out of Medicare, okay? And it was going to do it in 3 ways. One way is that it reduces the payments to providers. And the intent of that is to take out about $314 billion out of payments to providers, which results in about a 1.1% reduction per year. Now, the caveat in the reduction in services or payments to providers is that we kind of fail to calculate something, okay? And that is that it calculated in there a 31% cut for physicians in 2013, okay? However, do you all remember what happened on December the 31st? Congress met, and one of the things that they did is they said, we are not going to cut physician reimbursement by 31%. We are basically going to increase it by 1.2%. So, despite the fact that they are planning to save $314 billion by cuts to providers, they didn't cut the physician reimbursement. Now, they did do some cuts in the area of such things as ambulance services. They did do some cuts in the areas of end-stage renal disease. They did do some cuts to home care. So they did make some cuts, but they are not cuts that specifically are going to basically balance that $314 billion, okay? The second thing, that the way that they were planning to cut health care was that they were going to reduce the reimbursement to Medicare Advantage plans. And they were going to cut about $357 billion out of the reimbursement to Medicare Advantage plans. Now, Medicare Advantage plans are like Kaiser, United Healthcare, Rocky Mountain Health Plans, Colorado Access has a plan, so it's those kinds of programs, okay? And Obama has been at those guys since the day he got in office. What happened in the early 1990s is that Medicare Advantage plans basically said to Congress and the government, we can provide health care for less than what's called fee-for-service Medicare, or just being in an individual plan. And we can do this for 95% of what it would cost Medicare to provide care in the individual fee-for-service market. By the time Obama took office, it was costing 119% more to take care of somebody in a Medicare Advantage plan than it was in a fee-for-service plan, okay? So the first thing Obama did, I don't think he was in office 30 days, and he did an executive order to basically cut out 4%. And he has done several executive orders, including the Affordable Care Act, and so they are now at about 112%. I mean, we're still, higher than the individual market. So if you're not in a Medicare Advantage plan, but you have Medicare and you have a Medicare supplement, it's still costing significantly less to use that form of health care than it is to use a Medicare Advantage plan. And the advantages of Medicare Advantage, which is kind of redundant and part of the sales, has been that they could coordinate care, that they would be able to provide a central medical home or a place for you to be able to get all of your care. They would reduce unnecessary specialist care. They would reduce unnecessary tests and all of those kinds of things. But that has not really, if you will, borne itself out. And so there's a lot of discussion going on kind of behind the scenes now as to whether or not Medicare Advantage in its current form is really a cost-effective way to provide health care, okay? The other thing that is happening in terms of cuts is that they were going to save the other $400 or $500 billion by going after Medicare fraud. And again, we tend to think that maybe Medicare fraud is not a big deal. We don't see a lot of it in Colorado that's easily identifiable, although we do see it. A couple of years ago, I had a board member who called me and she said, "What am I supposed to do? I just got my Medicare summary notice and I have been billed for a wheelchair." And I said, "Well, did you, do something?" I mean, I am in fairly good contact with board members, but, things happen. And she said, "No, I have been running my assisted living facility like I have been for the last, 20 years. I didn't have any surgery. I didn't go to the hospital." So we appealed it, and we did get it taken off. But where we see a lot of Medicare fraud is actually in what they call upcoding. And what upcoding means is that you go to the doctor and he sees you for 7 minutes, which is kind of the average now. And instead of billing for a 7-minute visit, they will bill for the next code up, which is like intermediate or whatever that is. So they, instead of billing for a $50 visit, they might bill for a $75 visit. So if you build a difference of $25 per visit for 10 people a day, times $250, times a year, how much just, upcoding on one type of visit do you start to see in terms of the amount of additional revenue that comes in? And we see that in hospitals. We see that in laboratories. The big one we see in laboratories is things like the doctor will order a basic blood test. And when it comes back, it's got 24 different things. They've done a whole panel, okay? Well, and they will tell you from the lab side of things that it doesn't cost any more to do this whole panel. So that's why they do it, okay? But what it allows them to do is instead of billing $100 or whatever it is for that ordered test, it allows them now to bill $250 because they did the whole panel. Okay, so that's the kind of stuff that is going on. Happens in nursing homes as well, especially in physical therapy, where they will bill again for a limited visit because you as an individual can't tolerate a 15-minute session. You can only tolerate 5 minutes, but they'll bill for 15 minutes. There was an outfit at a nursing home chain out of California that settled for $102 billion.
Did you say B?
Billion dollars of upcoding for therapy services in 4 nursing homes over a 5 or 6 year period.
Wow.
It's crazy. And if some of you remember about 10 years ago, give or take, when Hospital Corporation of America, or HCA, the Health One guys, when they settled for, I think it was $98 billion with Medicare for basically fraud, and it was all upcoding. So that's the big area where this is happening. Now you ask me, what is Medicare trying to do on the flip side of this to stop this? Because the original idea was the Medicare Advantage kind of reimbursement, which is where they would get a specific amount of money to provide services, would stop some of that, okay? Well, what we've seen is an increase in the per diem, the per member per month amount that they get. So that hasn't worked very well. The other thing that started also back like in the mid-'80s was that we tried the whole diagnostic related groups process in order to cut how much we pay for hospitals for certain procedures, okay? And as you know, again, there have been numerous attempts over the years to cut hospital costs. And the current one, to be very honest with you, is I think there are 4 diagnoses. It's heart disease, chronic obstructive lung disease, I forget what the other 2 are. It's like a heart, 2 of them are heart related or circulatory related. And then the 4th one, I don't remember what the 4th one is.
Cancer?
No, it's not cancer.
Kidney?
It might be kidney. But what they're attempting to do with hospitals right now is that if you are readmitted within 30 days for the same diagnoses, the hospital does not get reimbursed. Okay? So it's incumbent upon the hospital to try to work to keep you out of the hospital. And there's a lot of things that are happening at this point in time, which I think are very good, actually. Because we are now looking at things like, instead of not bringing home care into your house when you leave the hospital until 24 hours after you leave the hospital, because that's the Medicare rule, we can actually start bringing some home care services in the day that you get released. We are starting to look at the fact that if you need durable medical equipment, that we get it there when you get out of the hospital instead of the next day or 2 or 3, and trying to prevent things like additional falls and those kinds of things, which we know just results in a rehospitalization, more sickness, all of those kinds of things. We're also coordinating with programs like Meals on Wheels, and so that you're not, trying to cook when you are still very frail. We're also looking at making appointments with your doctor before you leave the hospital, better communication with your doctor. We're also looking at trying to figure out how to get your meds, because a lot of meds, as you probably know, get changed in the hospital, okay? And then I see all these people who come home from the hospital and they don't know whether they're supposed to take the stuff that they got in the hospital, whether they're supposed to take the stuff that they had before they went to hospital, or whether they're supposed to take all of it, because there's no coordination of all of that. So we're doing a much better job of doing some of those kinds of things. Now, you asked the question, how does that sort of relate then to kind of end-of-life decisions? Well, one of the things that happens is that 1 out of every 4 Medicare dollars, or more than $125 billion, is spent on 5% of the beneficiaries in the last year of life. Okay? In addition to that, what we know is that if you have 4 or more emergency room visits, you are at probably high risk. 4 or more visits in a year to the emergency room. You are at a much greater risk of having a hospitalization, and probably death is going to occur within the next 2 to 3 to 4 years. So if you find yourself going to the emergency room, you're probably looking at, some end-of-life issues, okay? So if we are going to the emergency room 4 times a year and we are getting mixed up on our medications because we got new meds as we left, and we are, not having any kind of appropriate home care, you can begin to see how, as we get older and as we use more Medicare dollars, what then ends up happening with those expenditures. Another thing that happens to a lot of people that I find to be a very unintended consequence, if you will, of going to the hospital or using a lot of health care in the last 2 or 3 or 4 years of our life is your out-of-pocket expense. And the average out-of-pocket expense for an individual in the last 5 years of your life is $39,000. Now stop and think about, how are you going to pay for that?
Is that every year or for over 5 years?
Over 5 years. But that's a lot of money. You know, that's $8,000 a year of out-of-pocket expenses. And for a couple, it's $51,000, and if you have like a long-term illness like Alzheimer's, you're looking at like $66,000. So again, we're looking at a lot of out-of-pocket expense, in addition to what it costs Medicare. Okay, this is what you pay. So this is the deductible. This is your copay on the medications. This is your lab bill that's left over from your Medicare supplement. This is your Medicare Advantage 25%. This is the, however those are set up, and there's a lot of standardization in how we pay healthcare, but there's also a lot of variation. And what the Mount Sinai School of Medicine suggests is that more than 40% of households, these bills, these out-of-pocket expenses, actually exceed their financial assets. Senior citizens, the primary reason why they file bankruptcy is medical bills, even though they are the best insured in the country.
What's wrong with this picture?
A lot, isn't it? So if we are filing bankruptcy at the highest rate in the population, the highest cohort rate, and we have the best insurance, then that's telling us that we're spending a lot of money. And if we know that we're spending the majority of it in the last 5 years of our life, then who's left to pay those bills? Well, clearly it's a spouse. One of the things that happens also in this world, and we get these calls all the time in our office, is if I am married and my husband died and he left me with $20,000 of medical expenses, do I have to pay them? And the answer is yes. Okay? Now, if you are a single person, widowed or whatever, and you left $20,000 worth of medical expenses, it does not have to be paid unless there's money in your estate. If there's money in your estate, it has to be paid. But if you die without any assets or any cash in your estate, then basically you have no responsibility. So I, as an adult child, do not have to pay for my mother's medical bills if, in fact, she doesn't have any assets when she dies. Okay? Yes?
The other thing is if a person dies and the spouse's only income is from Social Security and or some other pension funds, they don't have to pay the medical bills.
That is correct.
Repeat that.
Sure. His comment was that if your income is Social Security only or some exempt paid pensions, not all pensions are exempt, but some pensions are exempt. If that is your only source of income as a surviving spouse, you can have the medical expenses forgiven. But you have to go appeal it, you have to go work with the medical providers, and it doesn't just automatically happen. You have to, do a whole bunch of proofs and those kinds of things.
So what would be the disadvantage of getting divorced then at the end so that you aren't liable for your husband's expenses when he dies? What would be the expenses of getting a divorce?
What are the expenses of getting a divorce? If it's no contested, I think about $150 down at the county courthouse.
Are a lot of people doing that?
I don't see it a lot. I'm not saying they don't. Those cases don't come across my desk. But I know of cases, but I don't see it a lot. Okay. All right, so where do Medicare expenditures occur? Well, the majority of people say that they want to die. Whoops. Hello?
Yeah.
The majority of people say that they want to die at home. How many in this room want to die at home?
Or in the woods.
Or in the woods? Okay. However, statistically, only 24% of us die at home, and 76% of us die either in a hospital or a nursing home. Now, let's think this one through a little bit. If you go to a hospital, what is the expectation?
Yeah, keep you alive.
To keep you alive. And we are going to keep you alive most of the time at all costs. And it was Ray, right?
Right.
Ray mentioned at the beginning of the meeting that you needed 3 documents, right? He said you needed a living will, a medical power of attorney, and a discussion with, you know, in my mind, the medical power of attorney. He didn't say it quite that way, but that's what I would think of.
I wondered why.
And the medical power of attorney's job, theoretically, is to A, get you back out of that hospital, or B, to at least provide or direct the care that you want, okay? Now, here's a big problem. A big problem is that most of us are encouraged to have those conversations with our primary care physician, right? When was the last time you were in the hospital? Did your primary care physician visit you in the hospital? So we have 2 things going on at this point in time. One is somebody either called 911 or the doctor that we went to said, you need to go to the hospital, right? And we were admitted.
Right.
The second thing is that the conversation that we have had about our advance directives didn't go with us. Because we are now sick. We are going to a medical institution and we are getting care provided by someone with whom we have not had a conversation about our advance directives. And by now, on my way to the hospital or in the emergency room, I am too sick to have that conversation. My power of attorney is probably trying to manage all the other paperwork and probably does not have much time in the course of an emergency room visit to say, wait a minute, the conversation I had with my friend or my mom wants to stop some or all of this. Because now we're in the chaos of the emergency room, okay? And my doctor, whom I told, you know, don't ever do this aggressive treatment on me, he's nowhere in sight. And we are dealing with a doctor or a series of doctors that we have never seen before, and we're not having that conversation. And how many times have you been in the emergency room where you don't just see one doctor, but you see 2 or 3? I am always reminded of an uncle of mine who ended up at Denver Health one night in the middle of the night for heart issues. And by about 5 o'clock in the morning, there had been, I think, 4 or 5 people in to ask him his history. And he finally told that last guy that if he asked him that again, he was going to punch him out. And, of course, my aunt was, you know, a little bit taken aback. And I said, don't worry. But I said, if you guys really need that information, why don't you just read the chart?
Yeah.
You know, just read the chart. He's told you guys 4 times. Why do you have to ask again? But again, so you've got 4 or 5 different physicians very often in the hospital in a very short period of time. And none of them ask you what you want about your advance directives. They ask you how they can treat you to alleviate whatever it is that's going on. So it's not a conversation we have.
How do you feel about DNR tattoos?
I hear lots of people threaten to do that. I am personally not sure that they would be heeded by the medical profession any more than a written paper.
They wouldn't see it.
It should be right where they have to go to do it.
Here's the other piece of that, because then there's this whole kind of discussion, and we have this discussion especially in the assisted living training, where somebody calls 911, takes an assisted living resident to the hospital, or the EMTs show up, not to the hospital, the EMTs show up, and somebody in that 5 minutes or whatever it is that it takes for the ambulance to get there realizes that this person had a do not resuscitate order, but now the EMT is there. So the next part of the question always becomes, how do I know as an EMT that the paperwork that you are submitting to me belongs to the person laying in that bed? And how do I identify it? Because all of our advanced directives do not have a photo ID on them.
So then can't that be averted before when the call's taken and the EMT never sent it?
Once you dial 911, it's over, my dear. It is over. And the other thing that I find with the 911 calls, oftentimes, is it happens with inexperienced staff. It happens with people who are panicked because they don't know what to do. And I got to tell you, if you fell on that floor right now, even though I am speaking to a group where I would assume that most of you have your advanced directives in order, I would probably call 911. I personally probably would call 911 because I don't know what to do. I don't know what is going on. And I also don't know enough about your personal situation to know that if you fell on the floor and you had a broken hip, you didn't want me to call 911 and get it fixed. Because most of you on a medical advance directive probably want a broken hip fixed. What you don't want is a ventilator.
Yeah.
But when you're laying on that floor, because you just fell out of your chair, I, as a non-doctor, as a non-nurse, as a non-social worker, have no idea how to clinically assess what it is that happened to you. All I know is you are on the floor and you are in pain. The next thing to kind of look at in this kind of discussion is what procedures are used in hospitals. And 9% of the people who go to the hospital had a breathing tube or a life-prolonging procedure in the last month of their lives. And in my mind, this is the kind of stuff that a group such as yours is really working to say, do I, in fact, want that kind of intervention in the last month of my life? Now, obviously, I don't have any way of knowing that that's the last month of my life, but is there a way that we can prevent that? And in my own mind, one of the ways is if we don't call 911, we are able to prevent that. But sometimes the calling of 911 is out of our control. But the second thing, which doctors are getting better at, and I really have to say that, is that there are now being discussions about that. At least in my recent last 3 or 4 years, and I'm power of attorney for a lot of people, I get asked those questions. So doctors are starting to say to me, would this person want that? Now clearly if it happens when you present in the emergency room, it's a little different situation. But if we've got 5 minutes of time, or 10 minutes of time, or 20 minutes, or there's labored breathing, but not necessarily life and death in the next, few seconds, then doctors are coming out and they are asking, would this person want this kind of care? So I think a movement such as Compassion and Choices has really clearly started to make an impact on that, because we're starting the conversations. And I actually recently had a situation where the person was not in hospice, was not in managed care, but they actually asked me, he did have pretty advanced cancer, and they asked me as his power of attorney if I wanted them to do aggressive chemotherapy. And you know, he's almost 80 years old, he had diabetes, and he had a history of heart problems as well. And you know, it was a really, really hard decision. And it was a hard decision because that man, I think, really wanted to live. You know, I kind of knew that he would want that aggressive treatment. And what I had to weigh against in that conversation was the fact that I didn't think he could tolerate the aggressive chemotherapy. So I opted for quality of life for the last like 4 or 5 weeks, as opposed to aggressive chemotherapy to maybe keep him alive for 6 or 8 weeks. And fortunately, I ultimately had to make that decision because I was the designated power of attorney. And when the discussions first started, his brother wanted him to get everything. They wanted him to go through it because, again, that's our mentality of we use all available means to try to prolong life. But as I expressed to him, to the brother, I said, you know, what we're going to have is the ability for your brother to be able to have some conversations with you, to have some visits with you. Yes, as time goes on, we're going to have to give him more morphine. So, because the doctor said that the pain was going to get very uncontrollable because it was both in the bone as well as in the brain. So we were going to eventually have to deal with morphine. But we were going to still get a few weeks, a few more visits of quality of life. Or did we want to have him as an individual basically nauseous and gagging and miserable from chemotherapy? And once I was able to present that difference in quality of life, the brother then started to see the benefit of not doing aggressive chemotherapy, but rather of let's do quality of life. And I think that's a shift as well. Because 20 years ago when my dad died, we used every available means, A, because that's what my mother wanted, but 2, because he had a philosophy which was that if God didn't want us to use all these machines and all this medicine, he wouldn't have given it to us. And he told me that more than once in his life, that that's why God allowed us to invent all of this stuff, because he wanted us to use it. And that's very born in the Catholic tradition of life. And 20 years ago, Catholic religion was very much into that. And I was pleased to read something just in the last few days where even the Catholic Church has taken a little bit different spin on some of this stuff, which is that it's okay to make an active decision and say, I don't want all that medicine, or I don't want that surgery. It's okay to give that permission and to not take advantage of it and not have it viewed as euthanasia. Okay? Yes?
I just want to share something with this group. My father would now be 105, I think. He was a coal miner, and that's how he worked himself through college and medical school. He was in the coal mines, and his father said to him, because he was dying of miner's lung, please give me something so when the pain gets too bad, I can take it. And he did. He gave him an overdose of, all I had then was codeine, I think. I mean, they might have had morphine. At any rate, he asked for the same thing when he was dying of cancer. And he also had congestive lung failure. He asked his friend, a physician, to give him an overdose, so he had it in his bedside table. I think this kind of thing has been going on longer than people realize.
Oh, totally. Yeah. Yeah.
And I think it is something that's important that other people recognize. This is happening not under the table, but in the bedside table.
Yes.
I would suggest you take no questions and no comments and no additions until you finish your talk so that you can finish it. Thank you very much.
I second that.
Okay.
I like this when there's more interactiveness.
Okay. Well, we clearly have a difference of opinion.
Right.
Okay. People can decide.
Hold on a second. At this point, I think you should finish your talk.
Okay, I can do that.
That's the most important thing.
All right. People can decide how they want to die. And one of the things that Obamacare or healthcare reform has done is it has now provided a forum for physicians to be able to basically discuss with their patients advance directives. And if you remember, one of the things that happened with healthcare reform in Medicare is that we got a whole bunch of new preventive services approved, but we also now have this annual wellness exam. And what this annual wellness exam is supposed to do is it provides an opportunity for you to go to the doctor once a year, have it paid for, have your blood pressure taken, have your meds reviewed, talk about your advance directives, and see if there's anything kind of going on, okay? So we now have a way for physicians to actually get reimbursed for having discussions about advance directives. Now, the biggest thing that, and I've known this for a long time, is that advance directives, even when people put their preferences in the medical records, 15 to 20% of the time, their preferences are there and nobody has read them or nobody has paid attention to them, which again moves this whole need for constant communication, okay? So even if you have the conversation with your doctor, even if you fill out the forms, you put the do not resuscitate forms in your file, you put the medical powers of attorney, all of those kinds of things, it doesn't mean that anybody's going to read it or that they're going to do anything about it. And what's even more appalling is that in a study that was done by the Agency for Healthcare Research and Quality, we basically see that 65 to 75% of the patients who had advance directives, basically their doctors were not even aware of them. Now that's pretty appalling because again, doctors are not paying attention to this. So let's look at another study that was done and what is happening in terms of the rate of dying in hospitals. And the Center for Disease Control basically looked at some retro studies, and what they did is they went back and they looked at 3 diseases: cancer, chronic obstructive lung disease, and dementia. And what they found over a 9-year period is that fewer people were dying in hospitals with these diseases. So we went from 32.6% in people dying in hospitals with these diseases in 2000 down to 24.6%. Now that is going to be statistically significant. And what that again starts to show is that we are moving people out of hospitals and we are moving them probably into nursing homes or rehab is where they're probably going. We do find, though, an inverse relationship, if you will, to how many people in the same study were in the intensive care unit the last month of their life. So even though people are dying less in the hospital, they're still getting very expensive care that last month of their life by going into the intensive care. So 24% were in intensive care. within the last month of their life in 2000. By 2009, that rose to 29%. So we're putting people in until we're taking them back out, okay? And sending them someplace else to die. The rate of using hospice is also increasing in that same study, and that has basically doubled in about a 9-year period, which is really, really impressive. However, the caveat in that particular study was that hospice was used for less than 3 days in many instances. So again, what I think we're starting to see, if we look at how the care is being delivered, this is my conclusion of this, okay? What we're seeing is that people go to the hospital, they go to the ICU, there's a terminal diagnosis met, we're put on hospice, but we're not on hospice very long, okay? And to bring an average down to 3 days in hospice means that there's a lot of people who are there for a very short few hours. Okay? Whoops, I'm sorry. Okay, here is the new guidance for nursing homes on from Medicare. And the most common causes of death in nursing homes are people with heart disease, stroke, diabetes, cancer, and Alzheimer's. Now that's not a surprise. Those are also the top 5 causes of disease in the United States. So what we then need to kind of look at is what are the factors that influence death in addition to chronic disease? And one is clearly age and your overall health condition and other comorbidities. But other things that nursing homes are now being encouraged to look at is things like, is there an unexpected acute illness? So was there a gallstone? Is there a urinary tract infection? Is there a wound? Is there a pneumonia? What's kind of going on at this point in time? And then nursing homes are also now being expected to start talking about what are the treatment choices. What does this person need or want? For example, about 25 years ago, a geriatrician over at the Veterans Hospital told me that an old man's best friend is pneumonia.
Right.
Old story.
Old story, very old story.
Yeah.
But how many times do we have a pneumonia aggressively treated? Because we can do it, and we want it, and we don't see it as fatal. Okay? So, what does the person want? And if I asked everybody in this room, if you had pneumonia, how many of you would want to be treated?
I would.
Yeah. You know, most of us see pneumonia as a treatable disease. It's a very different diagnosis than having a ventilator put in, or having a respirator put on, or having chemotherapy. It's a very different kind of decision process. So just within the last few months, Medicare has come out with some guidelines for palliative care in nursing homes. And so what are the clinical events that signal that the dying process is happening? And part of what they're encouraging them to do is to start look at what is the level of pain. How uncomfortable are you? Is it hurting? Can you tolerate the pain? Are you tired of the pain? And then another thing they're being told is to assess these conditions and what their impact is on the individual. So is the person always tired? Are they always short of breath? Are they no longer able to participate in things that they've always done? Are they having problems eating? Are they lonely? Are they anxious? Are any of those things kind of going on? And if the person says that they are having a lot of pain, believe them. There's always been this kind of suspicion, especially in nursing homes, that if an individual complains of pain and we administer too much pain medication, the nursing home will be cited by the regulatory agencies for using that as a chemical restraint. Okay? Again, not a very good thing. Another thing that they're suggesting is to use symptom control options that are appropriate for the resident. So again, you know, does yoga work better? Does deep breathing, deep relaxing, you know, how is it that we're going to eliminate the individual's pain? Do we have to give morphine? Do we give OxyContin? What do we give? The interventions also need to be given in a logical and coordinated manner so that we know what's going on. We need to empower the individual to basically be part of their care plan and to say, this is what I want and this is how I would like it. And the nursing homes really they have a good opportunity to do that. We've just never done that very well because we have this preconceived notion that nursing homes are a place to go to die, rather than nursing homes are a place to go to die, but with a quality of life, okay? And that's what this is trying to basically get at, is can we provide people quality of life?
You keep saying nursing homes, is that just a given with Medicare, that it has to be a nursing home? Can it be at home? Can it be outside of a...
Yes. This is just the new standards for nursing homes for palliative care. Okay? So basically what nursing homes are told to do at this stage of the game, since we know from the previous statistic that 76% of people do not die at their home, they die either in a hospital or a nursing home, if we're going to change the practice of how Medicare dollars are spent, and if we're going to change the practice of how people die, we have to go to the point in the public policy where people die. We can say, yes, we want to die at home and we want to change those standards, and I believe that those are probably coming. And there's been a lot of advance in the hospice world. But at this point in time, the big initiative last September was to basically encourage nursing homes to start to look at palliative care. And if you start to look at the services that nursing homes say on their little fancy brochures, what they're providing, palliative care is finding its way on their marketing brochures, okay? So the question then becomes, what is it that we're looking for and how is the nursing home going to be judged or evaluated, surveyed? And basically what they're being told is, you need to move from an acute care paradigm and you need to shift this to remedial. And your job is basically to relieve pain, okay? To provide comfort. And you're going to do that, if you will, by setting up a system that allows for that to happen. So you're going to have to provide more assistance with activities of daily living. You're going to have to pay attention to what is causing the individual pain. A lot of problems that people have in their later years is anxiety. And, you know, partially I think it's because if I looked at myself and I couldn't do all the things I wanted to do, but my brain was functioning, I would be really anxious. I would be really annoyed with myself because I'd be wanting to do all those things and my old little body wouldn't cooperate, okay? Other things that they're saying you have to do is you have to pay attention to hygiene and skincare. You know, oral care is extremely important, and a really, really big thing for nursing homes these days, as one goes toward end-of-life issues and palliative care, is wound care. It takes about 2 hours for skin to basically develop a wound. And once it develops a wound, those things are very, very hard to take care of. So again, nursing homes are not used to having people who are really sick and who are dying in the nursing home. See, we're more used to people dying in the hospital, so we don't worry about people needing to be turned and all of those kinds of things frequently in hospitals, because that's part of the routine care. In nursing homes, we're much more used to people being out of their bed. We're much more used to them sitting in their wheelchairs, as opposed to people taking more naps, people being able to rest more. But what that comes with then is a different system of care delivery, and it requires a higher level of intervention. And it's probably going to require a higher level of staffing on the nursing home level. We also need to pay attention then to the meds. You know, are we giving meds that provide palliative care, or are we giving meds that are curative? So are we sending this person out for dialysis 3 times a week? Or have we decided dialysis is not something we want to do? Are we giving meds that maintain blood pressure, which might provide a quality of life? Do we want to continue with all of the heart medications? So again, those are the kinds of questions that need to be going on as we are looking at what kind of palliative care standard and what kind of a care plan do we really want people as an individual to experience. So basically, the end kind of thing is spending all that money worth it? And there are 4 things that this one author suggests about the healthcare system, and he says he isn't sure whether they're going to save any money, but it's his contention, and I thought this was kind of a good way to end, with at least we should improve the care for the dying individual, and we should talk about the end-of-life care that they want. We should talk to the physician about our preferences. We should encourage hospitals and nursing homes to deliver palliative care, and we should provide training for those people. And we need to basically revise eligibility for hospice care. At this point in time, we still have hospice rules that say that the doctor has to certify that you're going to die within the next 6 months. Now, we have gone a little bit farther down the road, but we haven't been there very long, where you can get a 6-month renewal and then you can get another ongoing renewal. But that's a very recent policy change, and we're really looking at it again as a dying process in hospice as opposed to a quality of life kind of process. And that's, again, another one of those paradigm shifts. And maybe we'll come up with a new term, just like we've come up with a new term with the palliative care. Maybe we'll come up with a new term where hospice truly will be, you know, an end of life, last few days, and there'll be something between palliative care and hospice care. And that, you know, and that's part of what happens as we look at different healthcare delivery systems is what do people want, how do they want to be treated, and then that drives public policy changes. Okay, we have about 14 minutes left, maybe 12. Are there any comments? Let me take comments from people who haven't asked first. Yes?
That last slide before this one,
Uh-huh.
I wanted to ask a question on that. It says hospitals should provide palliative care services, specifically hospitals, and why are they concerned about that? Why is that in practice?
Why, it was this author's idea, and I would say again, hospitals are used to treating aggressively acute services. And again, if hospitals recognize that maybe not everything should be aggressively treated, so it's that same paradigm shift. Okay, you've had your hand up a couple times.
The difference between a 911 call and being taken to an emergency room in an ambulance versus if a friend can get you there, or you know something's happening, but you can get yourself there. Is there the same level of keep them alive, you know, like they do in the ambulance, in the emergency room, or is there a differentiation?
Personally, I've never seen much differentiation, but I can't tell you whether other people have. My experience has been when I've taken somebody to the emergency room, they go into overdrive, which is what they're trained to do. Yes?
I have a question of clarification. Early on, you said the Part D, that in the current changes, there's no money designated, and you said it comes out of the general fund. Does that mean the general Medicare fund or the U.S. government general fund?
The U.S. government general fund.
Thank you.
Yes.
I have a question about, again, something you started with, and that was under Medicare Part A, where you talked about what it would pay for. You said something about $1,182 every 60 days for something. Rehab up to 100 days, copay after 21, and then limited home health care. Can you be more specific about that?
The home health piece or the other pieces?
Especially the home health piece.
Okay. If you have had a 3-day hospital stay, what we call 3 midnights, you are entitled to Medicare Part A, and it's up to 100 visits. And that can include a skilled nursing visit, it can include CNA visits, it can include therapy visits. Now, that's how you get home health under Part A. There's also a home health Part B benefit that does not require the 3-day hospital stay. But it's basically the same services, it just gets funded differently.
Up to 100 visits.
Under the Part B, it's unlimited, but it's basically you have to prove it's skills care and it's medical necessity. And the definition of medical necessity will also kind of throw you away. It's not the medical necessity, it's like medical necessity for home care is like, can't even remember exactly, but it's like you have to basically pretty much not be able to get out of bed kind of thing.
What about dementia or Alzheimer's? Are there situations where you can get Medicare to pay for some in-home care for Alzheimer's person?
They usually will not pay for Alzheimer's. They would pay for something like blood tests, or they may pay for skilled therapy, but they're not going to pay for the diagnoses of Alzheimer's, because Alzheimer's is not one of those diseases that can get better. Okay? Now there is an effort, and I actually need to follow up on this. There was a recent, I think it was an appellate court decision, that all along for the last 40-some years that we have had home health out there. Home health has been, you had to be getting better. And once you reached a plateau, they discharge, okay? What this recent court decision, which I'm sure is going to be appealed, some more, but what this recent court decision said was that you no longer had to show that the individual was getting better, but that you could keep them on home health at a maintenance level. And if in fact that could happen, it will blow up the Medicare budget, okay? But what it would do is it would shift a lot of people, I think, out of nursing homes and out of hospitals, because we could provide a third-party reimbursement for home care. And eventually, if that holds in the courts, there'll have to be some still indicate or triggers, if you will, as to when Medicare pays for it, when you have to pay for it privately, and when Medicaid pays for it, for those people who don't have enough money. So it's still one of those things that's out there, but I was encouraged to see that we were at least moving away from the acuteness, if you will, of the definition of home health. Mm-hmm.
Along the same lines, and maybe you just answered it, but I thought I was missing something. I know somebody who has been getting home health care every day of the week for years.
But probably not under Medicare.
It wouldn't be any, that would then be Medicaid?
Probably.
Okay.
Probably. Because Medicare is usually more acute and you have to get better. There are a few instances sometimes, with some really frail people who have blood work kinds of things, and if you can prove that it would be unreasonable for the individual to go from their house into the doctor's office to get these kinds of tests and stuff, you can do them in the home care setting. But my best guess is, without a lot more information, it's Medicaid. Yeah. Any other questions from people who have not asked a question? Yes.
This is my first time at one of these meetings, so maybe I'm stepping into something here, but have you heard of something called allow natural death, A and D, instead of a D and R? That just seems more, it has less of a bad connotation.
So do you think it's the same document and it's just being called something different? I have not heard it. Has anybody else in the group? Oh, sure. Her question was, she said she'd heard of something called allow natural death rather than DNR, which is do not resuscitate. And she says it has a, you know, it has a better sense, if you will. It feels a little, yeah, it's a little more positive.
It's also broader
But,
because,
so,
because DNR is specifically.
but it's not something that I have heard anything about. So I'll keep my ears peeled and see if I can find any more.
Well, I was just going to ask about hospital doctor's bills. At the beginning of your talk, you talked a little more about the
upcoding.
Yeah, and I'm in a Senior Advantage, and so we get these explanations of the charges, but they we don't have to pay it. We just paid our copay.
Right.
And they seem unreal. They're so expensive. I had a biopsy, and by the time they got through with the doctor, it wasn't even a doctor, it was a physician's assistant, the lab and everything, it was $700. And
that's cheap.
This wasn't the surgery yet, this is the biopsy.
This was just the first day?
and the lab, and the interpretation of it.
Right.
And so I was wondering, I had just paid my copay.
Right.
What's the significance of putting down on the explanation of benefits what it was supposed to cost? Who pays that, or who does anything with that information?
Okay.
Partly because AARP is always telling us to check our bills.
Right.
And also Public Citizen.
Right.
Okay.
Let me just do a quick explanation. The first off, under a Medicare Advantage plan, Medicare pays AARP, United Healthcare, in your instance, X amount of money every month to take care of you.
Yeah.
Okay? And that is determined by your age and your health risk. Okay? So they're going to get more for you than they might get for her, or less, depending on how you present. Okay? And they agree, Senior Advantage or whoever they are, that they are going to take care of you for that amount of money. But in the guise of disclosure and transparency, they put those fees out there, okay? And they have to under Medicare rules, okay? They have to let you know what this is going to cost, or what this would cost if you were in a fee-for-service environment. Now, the other thing that happens then in the fee-for-service environment, so if you were just in straight Medicare and they billed those same kinds of things, instead of Senior Advantage getting maybe $500 or whatever they got for that, every single one of those procedures has an approved amount that Medicare approves. And the doctor then is allowed to, then Medicare pays 80% of that. You have to pay 20%, and then the doctor's allowed to charge another 15%, and anything over that has to be written off. So again, part of what they're trying to get at is there any comparability between all of those charges? And it's this whole transparency so you know how much this cost. But the thing is that the costs are inflated.
Yeah.
They're totally inflated. You know, or else you're paying for green grass, one or the other. And what I mean by that is, seriously, it's kind of like the colleges, you know, they tell you it costs, I think this morning, wasn't it $8,000 to go to CSU now? And so I asked the question, okay, what does that cost? And, you know, of course, they'll give you all of this stuff, but they always forget that it also costs for the green grass. You know, for the grass to look really pretty, we got to have a certain amount of that money has to go for green grass. Do I need that green of grass on a college campus? Maybe not. It's not that green in my front yard when I have to pay for it. Okay, I think it's 11:29. That's probably a good time to stop. What do you think, Ray?
I think it is.
Okay.
Thank you very much. So at this point, I'm going to adjourn our meeting. Our next meeting is on July 20th. Everybody is welcome. Bring a friend with you, bring your healthcare proxy, bring your doctor. Whatever you want to bring is perfectly okay with us. Thank you. Have a great weekend.